Welcome to Sage Women, the podcast where wisdom meets empowerment. I'm Melanie White, your host, and I invite you to join us for inspiring stories and evidence-based insights that support women's health. From expert advice to real-life experiences, we'll help you to thrive through menopause and beyond. And remember to hit the subscribe button so that you get the latest updates every fortnight. Hey, it's Melanie White at the Sage Women podcast, and today I'm really excited to introduce Associate Professor Erin Morton, who is the lead at the Vital Perimenopause Registry and the CEO of Bespoke Clinical Research. Erin, welcome, and thanks for being here today.
Hi, Mel. Thank you.
Very excited to hear about some of the innovations that you're doing today, and we'll be talking about a bit of your backstory, some of the work that you've done with the Vital Registry and why that matters and going into research. But could you just start by saying, why do you do what you do? Where does that come from?
I think, admittedly, growing up, I had parents in optometry, so very health oriented from the start.
Yeah.
We always used to get questioned, my brother and I, as to why, if we were taking in our parents' footsteps. Both of us were immediately no, but obviously part of that stuck. Always loved the idea of just being able to make a difference, and in health and medical research of all areas. The body is so complex, every individual is so different, that there's always another question. And when it comes to that, I'm a scientist at heart. There's always another question that I'm interested in.
Fantastic. And you do a lot of work, particularly in women's health, is that right?
I do. That's actually come about in the last few years, and it's interesting because some people sort of assume that where you're working is because you or a family member or a loved person has a condition or some issue that you're familiar with and you want to make change, and that is absolutely awesome. But I've gone about it a bit of a different way. So when I started in trials, actually I didn't even start in trials. I started in biotech because I knew I wanted to do something in science, but I wasn't really sure quite what. And biotech had a better chance of getting a job out of it because it was more specialized. So it wasn't that I, was one of those kids in high school that knew exactly what they wanted to do. I wished. But I was definitely drawn to the medical side, not surprisingly, as opposed to the ag side for me. Came out and worked in the biopharmaceutical industry for a few years. So that included actually making chemo and parenteral nutrition for people in the hospital. So working together with pharmacists in the little sterile labs and assembling everything and sending it off. But that's where I came across trials in one of my companies. We were 70 people in total, and once a month we'd all get together, and I kept hearing about these trials. So took my fancy. So looked around literally around the world to see what sort of areas there were. And interestingly, semi-lazily, what I wanted to do was something that would make a difference straight away, not just something that was going to be written up in a journal somewhere. Yes, absolutely. The peer-reviewed publications are things that do change practice, but for me, I really wanted to see that immediate impact. And there was actually, of all things, drugs of dependence was. There was the two top areas in the world. One was in Germany, one was in Adelaide. And my husband and I seem to keep leapfrogging each other when it comes to jobs, which makes it a little bit hard. As just when you get established, then it's time for the next one to move. So that did fit in well. And obviously, if in that area, you do make an absolute immediate difference. So catch my foot in the lab, tried out trials, and that's where I've been for the last 20 years now. So when I finished studying, then I went straight on to what's called phase 1 trials, which is effectively testing that a new innovation, a new intervention is safe in healthy humans. So it doesn't mean that the people you're testing it on has a particular condition, cancer being the exception, because often what you're giving is pretty nasty in itself. But that means every different discipline under the sun. So there was one, when I recall way back then, there was one that was a HRT, as was known then, but there was diabetes, there was pain relief, there was skin cancer prevention, there was basically anything under the sun. Which I loved. I loved all the different areas. I loved all the different roles that we could do. So being based in Adelaide, it's one of those almost catch-22s, in that it can be a lot harder to get a job because there's smaller fields here. But at the same time, if you do manage to do so, often you can do more because there are less people. You get to sort of put your fingers in more pies, in more projects, in different roles, and really explore what you enjoy and what you're good at. And from there, I spent 10 years in the cardiac space. And then, and again, got to do some amazing things. I've been fortunate enough to work with really brilliant clinician researchers. So a number of pieces of my work, both in cardiac and actually way back in my honours, are cited within international guidelines for the clinicians. So that's really exciting. And then, then I went, I do love cardiology, but I really used to love doing everything. And then so went back and broadened my scope and started again doing mental health, eating disorders, gastrointestinal cancers, like all various rheumatology, so Raynaud's disease, all sorts of amazing stuff. And as part of that, started working very closely with the women's and kids clinical director of our local hospital. So we had like 40 or 50 different projects going on at one point. Obviously, this was as part of a team, not just me. And during that time, perimenopause hit me. So that I freely will say to anyone, I had no clue about it beforehand. Even when I clued in, I still had trouble getting information because I didn't have the hot flushes, and I was still having periods, and I was 42 or 43 at that point. So even being a medical researcher of 20 years, I still thought, like most people do, that I'd be in my 50s when my period stopped with hot flushes. So I had access to not every, but a broad range of peer-reviewed publications because I was working at a uni at the time. I could tap my colleague or send him a quick text going, I can't find something. What terminology should I be using? Or whatever it was. And I still couldn't find what it was that helped me as an individual. So I went on and went, well, I've got obviously a lot of years of experience behind me, both in running clinical trials to make change, but also in registries. So a registry is effectively an ongoing survey where it means that it's not just the person experiencing whatever it is you're interested in now, but also next year, and also all the different sort of aspects that make it up. And when I started looking into potentially doing that for menopause, both sides, the one thing I kept getting told was that no one's asking enough. Now, as a researcher, you're very careful to actually keep the questions that you're asking very succinct. And I'm really bad with that when I'm writing or sometimes talking, but it's really important. It's something that we all make a really big effort to do, so it doesn't become overwhelming. You don't get fatigued and go, I'm just not going to bother, this is too much. We all know those surveys that they call you on the phone if you haven't blocked them, and they say it'll be 2 minutes, and
it's 10 or 15.
Almost, yes. But that was the thing. That was what I kept getting told, that unless you had particular symptoms that were really well known, people felt that they weren't asked about it. Or if they were asked about other aspects like work impact or family impact or, all these other things, that it was 5 or 10 different surveys that you wouldn't necessarily see, or it wouldn't have the same people answering those different questions. So both being very proud, but also my apologies. Vital is big. So I kicked off
Yeah.
the Vital Perimenopause Registry. Deliberately, there are only two questions that people have to answer, and that's in regards to whether you were born with ovaries and what stage you might think you're at the moment. But beyond that, it is open, so people can keep it to 5 minutes if they want. That's not the slightest worry. But if they do want to talk about their symptoms and what they think is most important for the community and how it's affected their work, or what sort of financial strain it might have caused. Now, for a lot of people, it might be fine. And honestly, that is absolutely brilliant. I wished I was one of them. But yay, that's great. Menopause isn't horrible, but it should be like anything else in that we know what the heck is happening to us. We can go to our doctor, get it recognized, be given a range of options, because again, we're individuals, different things will work for us, but also different things at different times. And then we should be able to just go ahead and go on with our lives. And effectively, that's what I'm wanting for menopause. That's what, from the sounds of things, most people are wanting. And that's what Vital is about. But I will confess, from a researcher point of view, because I'm interested in so many different disciplines, I love that. While I don't love it as a patient, as a researcher, I love that menopause, there are questions in menopause and cardiology. There are questions in menopause and mental health and diabetes and cancer and health and exercise and work impact, etc., etc. So while I started into it for one reason, or two reasons, I guess, my own experience, but also wanting to make it better for everyone else, I certainly think it will keep me occupied for a very long time.
That's amazing, Erin. And thinking about bringing together all of your past experiences and skills and strengths to pull together a registry that really starts to get that information about what is going on with women, what is the diversity of experience and symptoms and drivers and all of those things. I'm wondering what is going to happen to that information. Like, what does that registry and the data inform for you and for women in Australia? At least initially. I'm sure you would like to take it bigger than that, but
oh yes. There's a few different things, and I've tried to set it up in a way that it's open to all of them, because it is things that, not just as a researcher, but again as a patient, as someone with lived experience, I think is really important. So being effectively a baby registry, it was designed with obviously a lot of questions that I'd had. I reached out to a heap of people, and not just the clinicians and researchers that are standard sort of thing, but also a lot of community groups, a lot of advocates. So really trying to get those differences of opinion, because I realised that, my experience is different to what my neighbours might be. But then compared to someone in rural remote in a different state and completely different situation, then that's, their drivers are going to be different again. One thing I really need to be clear with research is that what has been done before has been great. But there's been particular ways that the research field used to work, which there's been so much effort over the last decade or two to change and to improve, which is just brilliant.
Could you give sorry to interrupt you, but could you give an example of that? What is something that might have improved?
Yeah, so I think the biggest thing would be the consumer engagement. So it used to be that, in the traditional conservative model of, I'm not going to name a decade, but at least in the 19s somethings, it was the clinicians know all. And then it might be the clinicians know all, but the researchers have a bit of a gauge. But it's now about, well, hang on, we need to actually ask the people that are affected by this. And it was interesting, even when I was back in cardiology, one of the examples someone gave, and it was written up in a publication in a completely different field. I think it was arthritis, but going back a while. And there was this question that the clinicians and researchers had come up with, and it was about trying to deal with pain. So great question, really important. And they did amazing things, and it was written up and it was brilliant. And then someone thought to actually ask the people affected, and they went, well, okay, the pain's not great, but we can deal with it. What matters is the functionality, because without the functionality, we can't go and get our groceries. We can't go and see our friends. And it's just that sort of thing. It's not to say that the other question isn't important. It is. But we need to remember the patient voice in working out what those priorities are. And then so there's been big changes, and they're absolutely brilliant. But then when you bring that over into menopause, myself as a patient, as a consumer, will have certain priorities because of my socioeconomic environment, because what my family's made up of, because of my job, because of my symptoms, because of my background health and family history. But then again, not just my neighbour will be different, but you might be different. Every listener might be different. And so that's where it becomes even more important, not just to go, okay, we need to measure the people that we can get hold of. And that's the other sort of caveat, the other not issue, because again, it's been formed by what's been possible. But before we had all our digital innovations, all our telehealth, all our amazing things, our electronic databases, the way that you did research was you brought people into your clinic or your office or whatever. So the people that were available were the people that were studied. And so
yeah, very different set of people, right?
absolutely. And so, over time there became guidelines to deliberately try to become more diverse. But at the same time, if by nature of what you're studying, you need to give a new medication and test the response a certain number of hours later or whatever else, you're not going to get someone who's working a 10-hour shift in a mine site. Whatever it might be, there's certain limitations that you can't get around. But that is where, particularly in something like menopause, where so much is our own experience, that by setting up a survey, by setting up an ongoing registry that is as broad as possible, and hopefully with where digital health is now, is accessible to virtually everybody. And I know it won't be absolutely everybody yet, but that's the point. That means we truly want as many different answers as we can. And so where Vital is at the moment is we'd had those initial questions, we tested them out, we've got it going, and effectively for the last year and a half or so, it's been in that pilot stage of this is where we think we need to ask, but we also know we don't know what we don't know. So I've been asking on every page, and I will be continuing to do that full stop because I think it's incredibly important. But what else haven't we included? From my own experience, I've got things in Vital going, okay, it might have affected your work, but what else did it? So I didn't have the hot sweats, but I'd have issues with sleeping through the night without sweating. And sleep is just so foundational to everything, or at least certainly for me, that if I couldn't get my sleep, then I couldn't do anything else. It didn't matter whether it was work or family or social or what. So I invested in new sets of sheets in a different material that would allow me to sleep a bit better. They were freaking expensive, and I was paid well at that point. And so it's like, well, yes, I could do it. But even then I had to work out, okay, well, when is this bill due? Or, does that kid really, or I really need to do that, whatever, to be able to make it happen. And so it's those sort of things that are never captured that we should be asking about, because it's not just what it costs us, but it also is the choices we make not to do things, and whether that's because of the financial impact of menopause or because of the symptomatic. And similarly, there was times when I drag myself out of bed and do work because that paid for food and mortgage and all the rest, but there was no way at all that I was going to sign up for my local sporting team, because the concept of doing anything else was not going to happen, even though I normally love exercise. Vital is about asking what we're not thinking about. And again, we'll have lots of different opinions. We're not going to make it 1,000 questions long, but by asking as many people as possible. And I think so far we have more than 5,000 comments. So one of the things I'm doing this year is looking for grant funding, which doesn't have ties as such, in that I can report what I find. And they have no right to any information except de-identified grouped information. But yeah, it means then I can look through all the comments and go, okay, well, this is really important. We need to ask more on this. Or we haven't had many responses or many comments on this area. Maybe that's one we can bring down a little bit. But we're doing a big push at the moment to get as many people as are willing to complete Vital, so we can get those opinions and improve in the right way.
We'll definitely be putting a link to the survey, to the registry, in the show notes for this episode. And it sounds like the data that you collect is informing research gaps, future research directions, and so on. And if that is the case, how does that work then? How do you translate what you're doing into research projects?
So a range of ways, in that number one is getting it out there into the awareness of the practicing clinicians and researchers. So I've been fortunate, have been applied and accepted. So it's competitive processes, but I was able to present something just that Vital existed at the Australasian Menopause Society conference last year. Also last year, the World Health and Medical Informatics Conference, I was able to do a poster there to say, hey, this is a new innovation that we're doing. The last year, a lot of Australians hopefully may have heard the World Menopause Congress was held in Melbourne, where I was actually able to present 3 different pieces of information. So one was on knowledge translation, which basically says, is that information that is being done from anybody in menopause, is that actually making it back into the community? So into the practicing healthcare, but from the patient's perspective. So what do we really think of what we knew perhaps before we hit peri or meno?
Yeah.
Maybe afterwards, if that's changed. Also, what do we think about our workplaces' opinion or knowledge, or our healthcare providers, which obviously is incredibly important. But along those lines as well, menopause has 1,000 different questions we could do research on. And as a scientist, I think they're all interesting. But again, what's the actual priority when there's not much funding, and traditionally women's health in general hasn't been funded well? Menopause and perimenopause particularly, a teeny weeny percentage. So if we are going to use up effectively some of that money, we need to make sure it's as impactful as possible. So in that respect, looking at priorities that all of our Vital people have said, whether it be mental health, whether it be the musculoskeletal sort of impacts, it might be the hot flushes, it might be osteoporosis. So looking at those sort of things. Was able to do a presentation on work impact. So whether we revealed at our work that we were having symptoms. If we did, was it during it or after you felt like you were effectively coping with everything again? Which I will frankly say I was in the second boat, even though in medical science we're usually pretty blunt about biology. But it was something that was something I really didn't feel I had a handle on and needed to get back where I felt confident before I said anything. But then also, was there differences? Whether that might be, and again, being clear, this was completely up to people's own choice as to whether they revealed it, and everything is, again, de-identified when I'm saying things, even in the massive group of responses. But was it to do perhaps with what our income was, or was it to do with where our role was? And we did find a small trend. And I am saying small, not so much because of the numbers, but because I know that we haven't done a big marketing thing with Vital. So it has been word of mouth. So I don't want to make any assumptions that what I'm saying represents the entirety of Australia. But it seemed to be that people that were more in senior roles were more hesitant to reveal what was going on at their workplace. So whether or not there's something more to explore there. But one of the other things I did, which I found both horrific and devastating, but also just I'm so thankful with what people shared with me. So I reached out to ask about the diversity of experience. And my original intention was that we got 26 people across Australia and New Zealand and effectively got a diary for 2 weeks, just at least a sentence each day, just saying, hey, what's your typical experience of perimenopause? And targeting the people that don't necessarily have a voice, again, aren't necessarily white, cis, metropolitan based, middle class, etc. And the people that wrote back said, really want to be part of it. Can I just give you a description? And so often, most of the time, it covered about a month. And it was intense and it was horrible. Sometimes to think that the way they were being treated happens in this day and age. But also it was eye-opening. And I think, again, it's not to say that we don't want to treat and improve for everybody, because we absolutely do. But we also want to make sure at the same time that we bring up the experiences for diverse individuals in a way that we can be proud of ourselves. So that was sort of 3 different aspects, I guess, of that side of it. But Vital as a whole, what I really wanted to do was create a foundation. So in science, you come up with an idea, and if you've got, you're associated with big names or whatever, and you get the grant, and that's all really wonderful. A lot of the time, and particularly for perhaps early or mid-career people or practicing clinicians, the ones who are actually seeing what's happening on the ground, they don't know all the research processes. They often don't have time for them, or they don't have the name or the backing to be able to write a really great grant application or get funding from this person or that person. It's just the nature of the game, effectively. That's what it is. But I'd love for a clinician in Sydney to be able to say, hey, I'm hearing this from my patients or from social media or whatever, but that's not what I'm seeing with my patients. What is the reality when it comes to Australia as a whole? Or a researcher in Perth, or a community member in Adelaide, or a PhD student in Brisbane, or for that matter, a policymaker in Canberra. So rather than every time someone has a question going, okay, I need to work out how to ask that question in a proper scientific manner so that the results can be reliable, but also every time they need to ask a new question, then they need to, in the case of a PhD student, maybe put up a poster around their campus going, do you know anyone who, and we've all seen those posters somewhere, it might be at the community centre, it might be, but yeah, and they might get, say, 10 people. And if they do, honestly, that's great. They can do a lot of questions in detail. But alternatively, if they can come to Vital and say, I've got this question, we can say, okay, what are you looking for? And they might say, okay, we want people over this age with potentially a particular comorbidity, which basically is just another way of saying you've got other conditions going on in the background. Or it might be that they've had this particular symptom and they're on MHT, so the new name for HRT, or it might be that they feel that they need to improve their diet or whatever else it might be. And we can say, okay, so when we filter down, we have, out of our thousands of Vital participants, we have X number or whatever percentage that fit all of those categories. And because part of Vital, we obviously information can be used to report Vital, the stats as a whole. But then we also ask people as individuals, every single one, do you want to be involved in other research so long as it's ethically approved? And that means they don't have to do a thing. It just means if they've ticked that box, then we can use that information and say, okay, so of our total percentage, 90% of them have said, yes, we're happy for it to be used ethically. And again, it's de-identified and grouped. So it means that we can go back to that PhD student and say, here's a, coded, but here's a set of information, and we've got 1,000 people for you rather than 10.
Yeah.
And
Yeah.
it just means we're not just speeding and also saving money, that then that student can perhaps go, okay, well, number one, I've now got this much more representative sample rather than the 10 people I could have got on campus.
Yeah.
But also, I had this other question, which if they'd had to recruit the 10 people and do everything more manually, they would never have got on to that other question. So it's about enabling people to do better research without having to start from scratch, but also hoping from a patient point of view, that means we can speed asking those next questions. And as I said, from different viewpoints. So it might be the policymakers have something in their mind from what they've heard, or, and it might be heard through family, or it might be elsewhere. But surveys and registries, although they're not as detailed as a clinical trial, and I say this with most of my work doing clinical trials, it's more real world, because it has to be. This is what people are reporting is going on themselves.
As you said earlier, we need to have the voice of the patient. And in fact, it's the client-centered or the patient-centered approach, really, isn't it, to include what the person wants into their own treatment.
Yes. So it's that I'm then taking amongst other projects, but there's things that obviously I've thought, or colleagues or collaborators, and again that's including consumer advocates, have all said, oh, this is an issue. And it's like, well, it absolutely is, but is that an issue just for us, or is this broader? And so again, early stage was, but starting to see some of those responses from Vital. So at the moment, and I have to be a little bit broad and general here, but I'd love to speak to you again in about 6 months and give a bit more detail. But we've got 3 different projects to do with menopause in ethics review. So any form of research is extremely strict and regulated in terms of making sure we're doing the right thing. And not just for the whole, but the patient takes, like the individual takes priority. But they're utterly different types of projects. So one's looking more at a data analysis of what has happened previously with no intervention, no change. This is just, again, really real world. One is looking at, again, trying to be as simple as possible to make change as quickly as possible. So what are some things that already exist that perhaps we haven't put together, or haven't put together regularly in a way that can improve patients' care? And then the other one is with a collaborator that has a new innovation, which I'm genuinely so excited about. But that one I really can't talk much about, sorry. But just to say, there is a lot going on in menopause. There is a lot that still needs to be done. And as I said, I could have 1,000 questions, but that's what I love about Vital. Not just can it provide that foundation for other people's questions, and if they have other questions, then that comes in either to me or to a committee to decide, okay, is this something that's appropriate? Or to answer this question, what other aspects should be thought of, whatever is most appropriate. But also it's then about, for my own ideas of, well, there's these 5 things I'd love to find out about, but what's the priority for other people? And that's sort of what's prompted, these ones. But also not scared. I loved the responses I got, but I sent out a bucket load of emails just before Christmas of, these are things that have been rattling around in my head this year, all sorts of different ideas and projects, not all menopause related, some more broader women's health, some really nothing to do with it. But, who's interested basically, and who potentially has some time, because obviously with busy, everyone's busy. So filling that in, and then that gives me a bit of a gauge on which ones to progress sooner rather than later, or depending on where people are employed or allied or whatever the case might be, what what funding or collaborative partners we might be looking at, because you can get done a surprising amount just with goodwill, but at the same time that still requires time of the people involved. So it's a bit of a balance.
Yeah, I mean, just to recap some of the things you said, it sounds like the Vital Registry brings the unanswered or hidden questions to light. You can use that data to disseminate it to people who are doing research, to give them a broader suite of information and a greater quality of information for their own research. Also identifying research priorities, recognizing that some of that decision making has to be about resourcing, time, money, availability of people who can support that research. But that you have picked out a few key areas, and I'm excited to hear about what your projects are in 6 months' time. I have one final question for you, Erin, and it's just in terms of the Senate inquiry that came out last year and the 25 recommendations. I know that you might not have done a deep analysis of all of your database, but how aligned do you think the recommendations were, if you feel like answering this or that you can,
No, that's fine.
with what's coming up in the responses?
I think they were quite well aligned. I think there were some things in the course of the inquiry that were said by, or either, said by whether it's the patients or people involved, that we knew, but it was good to be said out loud in the Hansard, and respected then in the recommendations. So things like the medicos not actually being traditionally given much training on this.
Yeah.
And again, it's not saying that everyone will experience symptoms, or if they do, that they'll be horrible. But at the moment, 1 in 4 Aussies are born with ovaries and 40 or more. So that's a lot of women, if I use it as a catch-all, that might experience symptoms. And you'd like to think that there was more from there. And there are new groups like, well, not new, very experienced practicing clinicians that have created new sets of information to try to help practicing clinicians now. But what the inquiries recommended in terms of introducing that at actual medical training stages is brilliant, because it means then we'll know that every person from then on, and then it's still a little bit of a catch up, which groups like Healthy Hormones can help. But I think that was a big one. I think some of the aspects of looking at that funding and that open-mindedness to, yes, there's people that have been traditionally involved in this, but I don't know whether this is the Gen X, but there's so many of us now going, well, hang on, there needs to be more. And we not wanting to take people's ground, we're just wanting to improve things for ourselves and for the rest of both our generation and our kids, for that matter. And I think a lot of what the inquiry was respecting was those reports from the patients themselves, again,
some of those lived experience stories were heartbreaking. I listened to the Western Australian one while I was driving to Canberra, actually, and I was just about in tears hearing a couple of those. And of course, we know that not many people have such severe symptoms, but when you hear those stories, early menopause at a time when someone's considering fertility, that one, I just thought, oh God, that was heartbreaking.
Yeah.
And we need to know about these things and all of these different permutations based on the intersectionality of someone's life.
That's it, exactly. And that's the thing. All in all, Australia, population-wise, is fairly small. But then geographically, we're so big that we don't necessarily hear about those other aspects unless we happen to know someone who happens to know someone, etc. So that, similarly, was devastating, but also enlightening. And actually quite early, one of the people I came across when I was setting up Vital was a person whose wife unfortunately lost her life during perimenopause. They worked out afterwards. They're based in Coffs Harbour. They've set up a foundation for her. And they work very closely with Monish's Her Centre, which concentrates on the sort of perimenopause mental health. But it's those sort of connections, and the more that we can do, and the Senate, I mean, to be unanimous in their recommendations was absolutely brilliant. And even the fact that they set up the inquiry, the number of submissions just kept going and going and going. And that's the ones, even as you said, the ones we heard, the ones we read. There was also other ones that were submitted and kept confidential at the request of the patient, of the person, effectively. And it's so much that needs to be done, so much that also then needs to be translated, because it is that thing of, yes, so many questions, but there's no point if it's not actually changing care. And I want menopause to be like asthma, like anything else, where you get an idea of what's going on because you've heard of it. You've actually heard of the reality of it. Your GP knows what's going on. If you need a specialist, and I mean then they know what's going on. You get a range of different medications. You work out what works for you. And again, that may change over time. And it may not be medications. For myself, I needed MHT to then be able to improve my exercise and improve my nutrition, etc. Once I hit menopause, as opposed to the peri peaks and troughs, I may not need. I may give it a go without. I may still need it. I don't know. But to have that that lack of stigma about this, it is a natural stage, but we need to be better about caring for ourselves and everyone else who's going through it, because that's how we keep ourselves happy, our families happy. We keep producing in the workforce. I spent 20 years getting to where I am. I don't want to give it up, but I probably would have if it had kept going the way it was. So, and that was just purely due to the intensity of my symptoms at that point. So, yes, it's about filling those gaps, but also making sure when we're doing so that it actually not even trickles down, but involves the right people so that it happens in the real world.
I love that, Erin. It's so rich. I could talk to you for hours, but what I would say as a nutshell of this conversation, I think, is that it's really clear to me from what you've said that we need to be talking amongst ourselves with other people and really being collaborative so that we can develop a unified approach which puts a range of options in front of the people who need it and that meet their diverse needs.
Absolutely. That's it. We're not one size fits all. We're not in anything else. We're certainly not in Meno.
And you can't know what you don't know. So we have to know in order to then understand what we don't know and work out the priorities. I'm really glad to hear that the Senate inquiry was so well aligned with what you're doing. That's great, because it might be fun to find new things. And I know you didn't say that, but then you think, well, what else don't we know and who else is struggling with those things? So the fact that there is that alignment sounds like what you have captured probably represents most of what people go through in menopause. Would you say that's?
I think so, absolutely. And it is that thing of, if we ask 5 people, we might have one commonality. If we ask 1,500 or 5,000, yes, there's some really big questions that can be dealt with by those really big groups. But it also, by asking more people, that doesn't mean we ignore the smaller questions that are still genuine questions. That might be the ones where we go, okay, well, this is a great honours study, or this is a great thing for a clinician who happens to be interested in that because for whatever reason they have a lot of their patients with it. There's so many different ways we can approach, and the best way to do that is to ask, and that's what Vital's about, and obviously me, but also then turning that into filling all of those gaps bit by bit.
Let's close the gaps. Thank you so much, Erin, for your time today. It was lovely to have you on the podcast. I really appreciate it. And we're looking forward to supporting you in 2025 to reach more people with your registry.
Thank you so much, Mel. It's been wonderful.